Medicaid Transformation Waiver Renewal Plans. And we have a keynote that'll be delivered by Yolo Akili Robinson, who's the Executive Director of BEAM, the Black Emotional and Mental Health Collective. Before we get started, I'd just like to remind you about some Zoom housekeeping. So the audience is muted and your video cameras are turned off. You should only see the panelists and the slides as they are shown. If you have issues with technology, please put those into the chat. There's only the option to chat the panelists, not the whole audience. And our tech folks will see your chats to the panelists and get back to you individually, also via the chat. If you have questions for speakers, please use the Q&A function, and we'll do our best to get to as many questions as possible. So please don't be shy about putting in questions. Both the chat and the Q&A functions are at the bottom of your screen. All of the sessions are being recorded, and all of the copies of materials will be available after the symposium on the Washington ACH website. So that's www.washingtonach.org. And now I'm going to hand it over to Diana Bianco to start this session. Diana, please go ahead.
Good morning, everyone. I'm Diana Bianco, Principal of Artemis Consulting, and I'll be your moderator for our panel this morning on advancing integrated care in Washington. This morning, we'll be talking about Washington's journey to integrate care so that we get to better outcomes for all. We'll be hearing about why integrated care is important and the history of this work in Washington. And we'll learn about the Washington Integrated Care Assessment, which is a statewide approach and tool to facilitate and promote integration consistently. It's an effort to standardize how we measure progress on integration as a learning tool at the practice level for both behavioral health and primary care providers, as well as to assess how Washington is doing across the state on integration. This work is the result of a successful collaboration over the last year between the Washington Healthcare Authority, the 5 managed care organizations that serve Apple Health, and the 9 accountable communities of health. And on today's panel, we have Colette Rush from the Healthcare Authority, Vicki Evans from Molina Healthcare, Susan McLaughlin from Healthier Here, and Greg Kleiner from Consejo Counseling and Referral. You'll get to hear their various perspectives of this work from a state agency, from an MCO, an ACH, and a provider. And you'll hear about what this work means for all of these entities and for improving health in Washington. We're going to put bios in the chat so you can hear a little bit more about our panelists, but we can get started right away. And we hope to have time for questions from the audience. So please use your Q&A box to post your questions, and we'll do our best to get to them. I'm going to now turn it over to Colette Rush from HCA. Colette, please.
Good morning, everyone. It's really nice to be here, and thanks for inviting us to share the work that we've been doing through a wonderful collaboration, as Diana said, and all of us will say this, I think, a wonderful collaboration and partnership between the Healthcare Authority, the managed care organizations, or MCOs, call them, and the accountable communities of health, or ACHs. With the passage of Senate Bill 6312 way back in 2014, if you can remember that, and based on the extensive work of many stakeholders before that to develop a transformation framework, Washington State embarked on a 5+ year journey to transform the Medicaid delivery system and to bring the physical health and behavioral health systems of care under one umbrella into one managed care system. As of January 2020, just last year, it's hard to imagine that. Lots happened since January of last year. This financial integration really was implemented in every region across Washington State, with one of its many goals that it would provide a structure in which to better support or facilitate physical, and behavioral health integration to occur at the point of care in practice settings, what we are calling clinical integration, and whole person care more easily achieved thereby. This would be a system of health that would best support individuals wherever they might seek care, therefore expanding access to care, as we all know. It would be a system that facilitates improved communication between providers and would provide mechanisms in which to better link individuals to critical community services. However, financial integration certainly doesn't guarantee or drive clinical integration. We realize that clinical integration requires a specific focus and set of supports. There has been a tremendous amount of work and support provided to practices that have chosen to integrate behavioral and physical health care within their settings over the last 5 years, though. This support has been provided by the ACHs through the Medicaid Transformation Project and through healthcare authorities' contracts with the managed care associations. And we know that there have also been many providers working independently to integrate healthcare in their practices. But there is so much work yet to be done in this area. The ACHs and MCOs have been providing support to practices in different ways and have used different tools or surveys to understand levels of integration. This can be a burden for providers who may be asked to complete multiple or duplicate assessments. The state has not had a common language with which to talk about integration or to know when a practice is integrated. What is the threshold for making that determination, for example? We haven't had a good way to know if there is improvement over time within regions or the state. Practices haven't been able to easily compare themselves to other practices that are similar to themselves. And we have not had a good way to identify where there are gaps in the system and where there is need for policy change or where funding and other resources should be applied. In other words, it's been kind of an apples and oranges situation. There has been a lot of great work accomplished, but we need standardization in order to understand the system and in order to significantly advance clinical integration across the state. So the ACHs, MCOs, and HCA decided to collaborate and launch a work group focusing on selecting and implementing a statewide standardized assessment, which can also serve as a roadmap for practices in their quality improvement efforts. We are at a new and exciting phase of our 5+ year integration journey and can now provide that specific focus and support required to further advance clinical integration. And we think this standardized assessment and quality improvement roadmap will help us do that by promoting whole person care with always the overarching goal of improving the health care and outcomes for those we serve.
Great. Colette, thank you so much. Vicki, would you like to share your perspective on this work as an MCO?
Yeah, thank you, Diana, and thanks everyone for being here this morning. And Colette, that was a great backdrop. Thank you.
I work with Molina Healthcare, but I'm really here to talk about the efforts that all the managed care entities have made as it relates to advancing integration. And I think one of the things that's really important is kind of go back in time and think about when we started the integration work and integrated managed care in April of 2016. And certainly there was a lot of work leading up to that kind of start of the MCO engagement with the communities and starting to have what we call the integrated managed care related to all aspects of work, financial integration, thinking about clinical integration and that. So it was an exciting time, but one of the things that quickly became apparent as we started working within different communities across the state was that we didn't have a common understanding of what integration was. We didn't have a way to really come together as a larger community across the state to define what the work was that we were trying to complete. There was also a lot of variation between different medical practices, behavioral health entities, both mental health and SUD, and also understanding that was very mixed by the communities that deal with social determinants of health and are part of our strategy, really, when we think about bringing the communities and our partners together to provide whole person care. So although we had a vision of integrated care, there was work to be done to really start talking systematically about what it meant. What is it we were trying to accomplish? What would the steps be? And how would we measure our progress? So I think the exciting thing I can say today is that we've made a tremendous amount of progress since April of 2016. We now have most providers understanding what integration is, whether that's screening for substance use and mental health conditions within primary care settings or in behavioral health, looking at how it is common physical health ailments could be, or chronic conditions could be addressed within behavioral health, The ACHs were stood up and have been integral to this work, both in terms of bringing partners together, physical health and behavioral health entities and other community partners, as well as really looking across the state through the ACHs, the MCOs, the Healthcare Authority, and other stakeholders to really think about it, how it is we work together to advance integration. So as Colette brought up, we decided through time that really one tool was needed. We had a variety of tools that were being used. MCOs had tools, the MIHAF was being used by the ACHs, and it was producing provider burden. And the provider feedback was that they were finding this work to be cumbersome and redundant, and that there were gaps for providers as it related to how we connected the outcomes of the tool to meaningfully support providers in producing change. And the ACHs certainly have been the closest to that and have done a lot of excellent work across the state, but there still was a further need for us to continue to come together to look at, again, how we can systematically collaborate to advance integration in these different service settings and to ensure that we really have good quality wraparound care. So identifying one tool we think will be very helpful. We think having that tool distributed probably once a year, finding ways that we will use the information, we'll both disperse the information and use the information, and having a way to really measure whether or not we're changing, and if so, where and how, and if we're not and we're having roadblocks, what are those roadblocks? What are they a result of? And how is it that we can collectively make those visible and look at whether we're going to need support from our system partners like the Healthcare Authority, whether there's something MCOs can do related to data or other elements, and or whether there's requests from the legislature as it relates to funding or other kinds of regulations that might be helpful to help support this work. As folks know, I think, the MCOs oversee millions of lives in this state and across the country, and a number of the MCOs are national entities. And so we have a very wide vision and the opportunity also to see what's working in different states and across the country as integration becomes more and more paramount and a priority nationally, as well as within Washington state. So I think this is very exciting work. I have to say, having been someone who's been involved in advancing integration for over 20 years, both in primary care as well as behavioral health settings, I think that we are making great progress, and I'm excited to see us build and for us to build towards something that collectively we can be more involved in and understand our progress and again, understand our barriers. So thank you very much for allowing me to speak today and to talk some about what the MCO's experience has been.
Great, thank you, Vicki, so much. I'm going to ask Susan to talk a little bit about this work from an ACH perspective.
Thank you, Diana, and good morning, everybody. Thank you for the opportunity to speak about this today. I am Susan McLaughlin. I represent Healthier Here, which is one of the 9 ACHs, but I am one of 3 ACHs that are represented on the work group. The ACHs collectively use a distributed leadership, so we can't be in all places at once. And so my colleagues at Elevate Health and North Sound ACH also participate with Healthier Here on the work group. And like Vicki presenting or representing the voices of all the MCOs, I'm really here to speak on behalf of all of the ACHs today about our role in this initiative and what we're excited about. So like you've heard from my colleagues, ACHs, as well as the Healthcare Authority and the managed care organizations and our clinical providers, we all really recognize the need to shift the system to whole person integrated care. And we know how important it is to improving outcomes for people that we serve. So it is so great to be part of this really unique partnership where there's such alignment around a shared value and goal. Collectively, I mean, you've heard from Colette, the state has been moving in this direction since 2014. Washington State has done a tremendous amount of work already at all levels to support integration. And so scaling to a statewide standardized effort really does seem like the natural next step and is really going to help increase the impact that we've been able to have. So I'm really excited about this effort because ACHs have been collectively working on supporting integration within our individual regions for the past 5+ years, really. And this new effort, or really an evolving effort, I wouldn't even call it new, I think it's the next level really builds off of what's happened and is taking it to scale and impacting a greater number of providers and people. Under the current waiver, one of the required projects for ACHs has been the bidirectional integration of physical and behavioral health. So all 9 ACHs have been convening stakeholders and bringing partners within primary care and behavioral health together in our regions to talk about what this means, what some of the barriers are, what the opportunities are, and what it's going to take to achieve this goal. And one of the ways ACHs have been supporting this effort, and Vicki alluded to this, is by collecting assessment data on the level of integration for a subset of primary and behavioral healthcare providers that have been participating in integration projects. And I say that because I think we have a really great model to build off of, and we're not touching all of the providers and practices to advance integration. And so this effort will really allow us to do that, and for providers to have equitable access to supports to advance care. We've been collecting data twice a year since about 2019, I think, is when we first started it. We've learned a lot through that implementation. And then in addition to doing the assessment, ACHs have been fortunate enough to be able to use our waiver dollars to support providers in their integration activities. So for example, we have made investments in infrastructure and capacity. This ranges from help with electronic health records, building staff capacity, developing client registries, implementing screening tools. ACHs have been supporting training, technical assistance, and practice coaching around different models of integration to various practices. We convene learning collaboratives where we're bringing providers together, sharing best practices, identifying barriers, and learning from and supporting each other as we go on this journey of change. And it is a journey, and it is a lot of change. And then we also are investing in tests of innovative models of integration. Nobody really knows what this means or what this looks like, right? And so we have this ability under the current waiver to do some flexible, catalyze some new ways of doing it and see what works, and that can be scaled, again, across other providers as we further define that vision. What's exciting about the new tool in process is that it's going to provide a framework for integration that will really help support and I think kind of change fundamentally how we think about clinical integration on the ground, because it's a framework tool. And so it's more about the different components of integration. It also, as Vicki and Colette have mentioned, really lends itself to continuous quality improvement. And that's really the goal here. It's not about a score. It's not, about, a single measurement on any one thing. It's about the conversation and the quality improvement activities so that we can advance the system collectively. We really appreciate that there are complementary tools for primary care and behavioral health within this framework. This allows for consideration of the unique differences and the different ways to approach integration in each of these settings. So I think that will really benefit, again, kind of the process and how we think about integration. We've been able to see at the ACH level the value of doing the assessment at the regional level through the waiver. And so one of the things that does excite me is this quality improvement opportunity. As we collect data, and as Colette was saying, we now are collecting apples to apples instead of apples, oranges, and pears across the state. We have a mechanism to then work with providers to identify specific areas of focus or needs. It might be by region where there's gaps. It could be by provider types, and then really drive resources to those focus areas and really be able to tailor the support through training, whether it's training, technical assistance, practice coaching, whatever that support looks like, tailor it to both individual practices and then also on a statewide basis. I won't repeat. I think folks have talked about the efficiencies and less burden for providers. That's really exciting. We know how overburdened providers already are, and so we want to streamline things as much as possible. I think it will do wonders to have a statewide perspective where we can measure progress across the state. The state of Washington has invested so much into the shift to integration. And again, we know how much has already been done. Providers are behind this. They're doing so much on the ground. There's been a lot of support. And we want a way to be able to tell that great story and actually show what the progress has been. And then the last thing that I'll say is that, well, actually I have two more things, but one is the very positive outcome that is the result of this collaborative model. I cannot say enough about what it has meant to have ACHs, the managed care organizations, and the healthcare authority, and then with the support of providers and the provider associations across the state coming together. We have this shared goal, and to say, you know what, we're going to co-create this and design it together so it benefits all and it works across the state. And I think it's a model that we can and should be applying to other initiatives that we do statewide. One of the things that this tool and framework is helping, I think it's a sort of an unintended consequence, but it was the first conversation we had when we started the work group, which is what is the vision for integration in Washington state? And that's been a very hard thing to pin down and articulate. And the conversations and then the use of a framework like this is really going to be able to help us get closer to articulating a shared vision and everybody rowing in the same direction. So that has all been really great. And I think, you know, ACHs are very well positioned to continue these efforts. We probably, I'm sure we'll talk a little bit about the renewal waiver and the opportunity under that to continue to support integration should that go through. But I will pause there. And again, thank you for being allowing us to talk about this and share this exciting effort. So Diana, turn it back to you.
Thanks so much, Susan. And we're going to talk more about that work group and the collaborative effort and appreciate you raising that. You also talked a little bit about providers. And so we'd now like to ask Greg Kleiner, who's a provider, to talk a little bit about his perspective on this integration work and the new tool and framework. Greg, please.
Thank you. Thank you, Colette and Vicki and Susan. It's an amazing platform to build on. So I work with Consejo, and Consejo works in three major areas. We work with Healthier here in King County, with Elevate Health in Pierce County, and with Cascade Pacific Action Alliance, primarily in Mason County. And in each of those, I love what Susan said. We have innovative models and we'll see what works. So in each of those, we've tried different innovative models. And in each of those, we've gone through, and I was thinking about this the other day. You know, you hear the word assessment and you kind of get like, okay, 7th grade, oh my God, they're going to test me and I'm going to get a score. And then I got to go home and I got to say, here's what my score is. And this has been a really interesting journey through what an assessment is supposed to really do, which is to give us some idea about where we are compared to ourselves, potentially where we are compared to others who kind of look like us, but nobody really does, because we all know we're unique. And then what are other people doing? So can we draw ideas from others? So there were 6 of us who were the guinea pigs in this whole thing, where the rubber kind of met the road, and we're going to try this out. And how does this work? And what does it look like? And we were geographically all over the state. We were practice-wise from hospital systems to standalone to integrated systems. And surprisingly, there was a lot of unanimity in what we wanted to do. So what we've experienced at Consejo is we've tried to do, let's take one of our providers and place them in a physical healthcare setting. We've worked, that was in Pierce County. In King County, we've used 2, we had people come in, healthcare providers come in on a regular basis into our main site and provide physical health care to clients. And in Shelton and Mason County, we have an active physical health care clinic in our building. So we run, we can walk down the hall and make sure that everybody gets care. To understand how those work, we've been able to use the MEHAF at least twice a year times 3 Some other assessments that MCOs have sent us, some other assessments that kind of just float in from somewhere. And we spend a lot of time running through these. What was exceptionally exciting about this particular framework was it encompassed all of it. It said, how are you doing here? How are you doing there? Can you compare this site to that site? Can you dump it all into one? And it said that from, as we looked at it, if we handed this off to our physical health care collaborators and they went through it and looked at us and we went through it and looked, can we come together and then have a conversation about it using the same questions, same language, and really come up with some ideas about where to go? And it would. It also would be a single point that we could do during the year. I think Vicki mentioned the fact that the provider feedback was, yeah, we really want to do one more assessment this year. Just send us 2 or 3 more to do because we have lots of time and we really want to get the teams together and we want to have these deep discussions about what this piece of paper meant, and then someone would go off and do it. To bring this down to one, where all around the state, everyone would have information, we'd feed it in, and then the data would come back to us individually, regionally, statewide, in a de-identified sense or in a specific sense that would help us move forward in a collaborative way, in a way that is positive and not necessarily in a way that, oh my God, I'm afraid what my grade's going to be, because it really is, how do we get better? Not, you're not doing good enough. It's just, where are you now, and how do all those levels up above where we sit, how do all those other levels all the way up to the legislature defining where dollars can go, how can all that assist us in making the job that we really all do, which is providing care to people, to make that job better? And that's what we're all about. So I thank you very much for allowing me to be part of this. This has been exceptionally exciting to me, and we'll go back.
Great, thank you so much, Greg. Vicki, you had something to add, I think.
I just wanted to add, thank you everybody for all that you've shared. And I want to build on something that Susan brought up briefly, which is, at the end of the day, what we're doing really isn't about the assessment. It's about us being able to figure out
how our delivery system is working, how integrated we are, what's working for those we serve, what's not, what's working for all of our community partners, our physical health providers, our behavioral health providers, and that. And for us to then think about what the technical assistance and support is that will be needed so that we can engage effectively in the work and driving results regionally as well as statewide. So as we think about this, I think thinking about really our clinical integration work, and then this assessment tool is a way to sort of measure our progress. And to Greg's point, I think we want to make sure that people don't feel evaluated by it, but I do think we want a way to evaluate the system. And part of learning, as I think we all understand, is being evaluated. We've all been evaluated for certain things over the course of time. And oftentimes that provides invaluable feedback. And some of that feedback is where we're doing well, where others are doing well, and how it is we continue to build off each other's efforts. So I think to be the most effective, we have to really look at this as being a team effort across the state among all of us as stakeholders.
Thank you so much, Vicki. One of the questions I have, and each one of you touched on this in a little way, is I do something, I'm in healthcare policy, and I have something called my brother-in-law test. Will my brother-in-law understand what I'm talking about when I say integrated care? He's a really smart guy, but he doesn't pay attention to what integrated care is. Why is integrated care so important in Washington? Why have you all prioritized this, whether it be from the state perspective, the MCO, the ACH, or the provider perspective? Who'd like to jump in first? Go ahead, Vicki.
Yeah. So I think from an MCO perspective, because we have so much data and we can see utilization for those that are members of ours, we have the ability to see
that they're involved in care, but they're not really getting whole person care. So someone could be involved in behavioral health, have physical conditions that result in, first of all, result in not getting the care they need, which then result in higher utilization through ERs, hospitalizations, those kinds of things, for conditions that could have been well managed, whether we're talking about something like hypertension or diabetes or whatever. So things that we could easily tap into and learn about and work around, wraparound referrals. From the same aspect, we have primary care delivering lots of great services and doing a good job, but not understanding that someone's not progressing with certain kind of health conditions because they aren't addressing behavioral health issues that are concurrent, whether that be mental health, substance use, or both. And so really having, I think as we would probably all agree as we seek our own care, having a place to go where we know that they're looking out more comprehensively for our well-being is really what we're trying to get to. And I think that the driver for that is good quality care, early identification and access to treatment, which we know is challenging right now, given all the things that are going on in our state. But that's why I think we want to, kind of look at what the overall goal is and then what we're going to do in light of our current situation. So at the end of the day, this is about better quality of care. And theoretically, also, we believe that if we provide more timely care and people are less sick, or don't advance to become more sick over time because of early identification of risk and education in that will save money in our system, as well as human suffering. And that then those funds could really be directed towards other areas that are needed to help support and buoy up having a really strong healthcare system, including medical, traditional physical health, as well as behavioral health.
Great, Vicki. Thank you so much. Colette and then Susan, and then Greg. We'll have everybody have a chance.
Yeah, and I think too that it just at the most elementary level, every time a person goes to see their primary care doctor, or if they're getting substance use disorder treatment or mental health treatment, it's an opportunity. It's an opportunity to provide whole person care. And so if care is integrated, or there's sensitivities around, like in behavioral health settings for certain general health conditions, or in physical health settings for behavioral health screenings, there's just an opportunity in which to serve that person where they might not have got received that care elsewhere. They might have not gone elsewhere. Maybe they can't go. They're limited on transportation, or their comfort level, whatever, as we all know, whatever it may be. So I think that's another real important aspect of clinical integration.
Thank you, Colette. Susan.
Yeah, I was just going to build on the business case with the data, although I'm not super have it all at the top of my head, but we do know that people with mental illness die on average, significantly sooner than people without mental illness because of preventable physical health diseases that aren't being treated, whether it be an access issue or a stigma issue or just health literacy issue. We know people with about 2/3 of people with mental illness also have co-occurring substance use disorders. We know that many of the drivers of health and well-being are things that happen outside of clinic walls. We also know that the access to behavioral health treatment is very, very low. And integrating it into primary care settings increases access, especially for people with mild to moderate conditions that can be well served and prevent, as Vicki was saying, something more significant or severe that can happen there. And then we also know that there are psychiatric medications that cause medical problems. There are many sort of interactive effects of medical conditions with the onset of things like depression or anxiety, so that co-occur with that or contribute to that, and vice versa. And so for all of those reasons, our approach really needs to be to the whole person. And the best way to do that is create systems that look at the whole person from start to finish when they walk in the door, and make sure that if there are needs in other areas that might not be my area of expertise, I am making sure that person has had a primary care visit in the last 12 months, has had their follow-up, is getting their blood pressure and their weight checked, and so forth. So thank you.
Really appreciate that. Greg, what's your perspective as a provider?
So I'm going to take this from a Consejo perspective, because it's unique, I think. So providing culturally and linguistically appropriate care, and providing that to people who are both are recipients of Medicaid, and to a significant population who are not recipients of any insurance. Understanding that social determinants of health for immigrant and refugee communities, some of whom are monolingual, some of whom speak languages but don't read the languages, and figuring out how do you make those presentations when individuals and families come in. The integrated care means that if someone comes in for either physical health or behavioral health issues, that literally you can walk down the hall and make sure that they get that the care is given, that it's immediate, that you can do interventions, and that the staff in the two agencies understand who can bring what to bear. So if you need immediate medical attention that needs to be that has to be raised to a different level, a doc can have a conversation with another doc. If a doctor has, or an ARNP or a PA has someone who comes in who has a physical ailment that is masking a behavioral health one, that care can be given immediately. And in the populations that we serve in throughout our system, being able to do that across populations that have been traditionally underserved or not served. And one of the ones that we're talking about internally a lot is that just because people come from South or Central America doesn't mean that Spanish is the primary language. There are indigenous languages. There are indigenous language groups that we've had to try to figure out, how do you even get translators for? How do you train young people who are members of families to do the translations that need to happen? How do you encompass traditional medicine, non-Western not modern American medicine into giving care, because that's necessary. And how do you deliver messages about, for the last 18 months, about COVID and pandemics, and now the flu, in a way that is translated out so it's understandable in a whole variety of languages and groups and cultures, that it's not the primary message delivery system is not aimed at. So that's been and what I will say is that the support from the ACHs, the MCOs, and the state for that has been exceptional.
Great. Greg, thanks so much. And all of you sort of touched on this, but it's this whole person care, but it also is really critical to equity and reducing or eliminating disparities, that everybody should be getting this kind of care that can really make a difference for their health. And ideally, it's in a way that we're not disconnecting the brain from the body, right? That you're seeing the whole person. I wanted to, we have a number of questions in the Q&A box that we'll come to, but I did want to come back to Susan. You touched on this, and everyone else did too, but I'll start with you, Susan. Just talk a little bit about the work group. And this has been a collaborative effort. It's ongoing. I've had the privilege to work with all of you on this. And can you just talk, you said it was unique, you said it's a model. Can you talk about why, what makes it unique? Because it's ongoing. And then I'll ask others to chime in as well.
Yeah, happy to do that. Thank you. Well, I think it's unique because the stakeholders, HCA, ACHs, and MCOs are there with a shared goal and are co-creating. And it's not often that we actually design something together from the ground up. Usually it's designed somewhere and then it's brought out and said, what do you think? Is this, does this work? Is it a good idea? But the work group has really taken on all aspects of from the initial charge came because I think there was a recognition that providers were being assessed multiple times using multiple tools, and it was preventing, not only was it burdening providers, which is a big issue, but it was preventing anybody from being able to tell the whole story because there wasn't any way to talk about it in a consistent way. And so the work group started with reviewing all the tools that were out there, the ones that were currently in play, what was being used by ACHs, what was being used by MCOs, what other national tools were out there, and did a really comprehensive analysis around the selection of a tool. We did the pilot, to test the tool, get provider input. We really have amped up our provider and stakeholder input over the last several months, especially as it relates to implementation and how do we do this? How do we do it well? But the work group has really taken this on themselves. Collectively, we create subcommittees when there is a particular, like we had to have a conversation about scoring the tool to make a recommendation. And so a subcommittee was formed and they came back to the whole group with a recommendation. So every aspect of it has been kind of a shared co-creation and recommendations up to the healthcare authority about how to do this and how to do it well. And so it's been really refreshing because I think it's going to increase its success on the ground as a result of having everyone involved from the very beginning.
Thanks so much, Susan. Anyone else want to chime in before we go to the next question? Vicki, please.
Yeah, I would also add that I think it's taken us out of competing around whose tool's better or who's, should we use Molina? Should we use the NIDA? Should we use the NEAP? Should we, whatever. And I think it's allowed us really to come together and say, hey, we need to be unified here. It's not really about the tool again. It's about having the right tool to be able to evaluate our system and know what we're doing and what providers need for support. But let's get on the same page and let's make sure that as we work with the provider community, that we really are aligning with each other and with the providers so that at the end of the day, this is about collectively how we all perform. We all have our part. And I think that has been really beneficial because we're drawing from kind of the best and the best thinking that we have, and based on a lot of experience with many of us that are part of this work group that have decades of experience in integration, but don't have all the answers by any means, because this is the first time we've done this in this state, in this way, and in these regions, and with ACHs and many, many other variables. I think the other thing that's been really great is to have the healthcare authority at the table. And we've been very fortunate to have Colette, who has decades of experience in integration, a lot of expertise, is very passionate about this, and is also working within the healthcare authority to bring healthcare authority stakeholders together to talk about what's needed and how to support this work as part of this work group and part of the larger community across the state. And so I think it's been a wonderful opportunity, again, for everybody just get together and say, how are we going to do this? Where do we want to get to? And as Susan said earlier, that was more complicated than I think we thought it would be. And I'm sure that will continue to evolve as we climb up the ladder and get better. We're going to have more vision and more ability to see off that balcony and that level. So we'll continue to improve this and our ideas as we move forward. But getting us all to see the collective benefit of aligning was really a first step. And I think we've done a good job with that. We've also had a lot of community input, and as Susan had referenced earlier, professional associations and that, and we've done a pilot. Maybe somebody wants to speak to that. So we've, I think, done due diligence in terms of making sure that we're bringing lots of different voices and that we're doing some trial of what it is. We might also want to mention that the National Behavioral Health Council is also looking at using this tool and working also with Dr. Chung and others to see how nationally we can look at other states that are doing similar work. So we'll have that also to tap into as increasing focus is put on this nationally.
Thanks so much for that, Vicki. And I want to
maybe for a minute.
Yeah, so a couple things. I wanted to just mention the provider engagement that you talked about, that there has been a provider advisory group, and we've gotten provider engagement through that. There was a pilot, which I think maybe Susan and Greg could speak to a little bit. And you mentioned Dr. Henry Chung, who came up with this tool with his colleagues. And as far as we know, Washington is the first sort of state to take this on a statewide basis. So really on the cutting edge of trying to be consistent about integration across the state. Let's talk for a moment. I want to be sure we have some time for the questions, but let's talk for a moment about some of that provider engagement and the pilot, just real quickly. Susan, could you chat about that? And then Greg, as a participant in the pilot, could weigh in as well.
Yeah, happy to. And I think Greg alluded to this when he was talking before, but we were fortunate to have a little bit of funding from the Healthcare Authority to support a pilot of the tool, because we really wanted to get the provider perspective. If we were going to implement it statewide, we needed more information about the tool, how it works, the questions, but also what does it take for a provider organization to actually do it, and how did they feel about it compared to the other tools that they were already using. How did it compare to that? And so we had 6 providers that participated in the pilot. 3 were primary care providers and 3 were behavioral health. And as Greg said, they were all over the state, some rural, some urban, some adult. There were pediatric practices involved. Some were standalone and some were integrated systems. And so we really tried to get the variety of perspectives that we're going to run into when we scale it statewide. And we had Dr. Chung came and did a couple of webinars with the practices and their teams, the teams from the various practices that were going to complete the tool, on how to use the tool, how to complete it. We did the first webinar initial training, then they went back, looked at it kind of internally and talked about it, and then came back with their questions. There was a second webinar. And then there was a period of time where they completed the tool. I think there was probably 6 weeks that we gave them. We had technical assistance available the whole time, so that if questions came up as they were digging into it, that they could get those answered. And then they submitted the data in electronically. We created a really, hopefully Greg can answer if it was user-friendly, but simple way for them to deliver the outcome of the assessment back to us. And then we had a couple of debrief sessions, which were probably the most important piece of all of this, because it was there that we had the conversations. What worked, what didn't work, what do you recommend, what would be needed for implementation, how should we be thinking about this? And we gathered all of that information and then brought that to the work group to inform the recommendations that came out of that work to the state, to begin to think about what would an statewide implementation roadmap look like. So all that was done over the summer, I think, of the second quarter of this year. And so, Greg, I don't know what you would add from your experience, but please jump in.
So what was impressive about the framework that we used, first of all, yeah, it was very easy to get the information back and actually utilize it. It was challenging to answer the questions because of the way that they were phrased, some of which we came back and said it'd be better to phrase it a different way. But and what was really impressive is it came out of a system that used this, and it came out of a system that had integrated clinics and didn't have integrated clinics. And so they could compare one to the other inside of an enormous system, and with the Montefiore system. So, I mean, that's where the tool kind of originated. And that brought physical healthcare and behavioral healthcare together in some of the poorest urban areas in the United States, and came out with some, how do we track this? How do we make this work? How do we watch it? So it came out of a place that was actually doing the work, and then it got, and so it was easy to then respond to those questions, because they were like feet on the ground questions. And the 6 providers that were part of this, along with the MCOs and along with the organizational, the conversation that occurred about how do you shape this and how do you really draw the data out and how do you make the data useful, so when the brother-in-law gets it, right, when it translates up like that, that it's understandable, it's an understandable answer to a legislator who may have no knowledge about what we're talking about, but the answer makes sense. And that, to me, was the key to this tool, that we can answer it from a provider place, that it would then go to MCOs, it would go to the state, eventually get translated out to funders in a way that made sense in terms of how do you get the economic power driven back down to provide better services.
That's great. Thank you, Greg, so much. I want to ask a couple questions have come up from the audience about the populations that are being focused on. And so there was a question about, has the integration effort been focused on adults or children or both? And there was a question about specifically transgender and gender diverse populations, and how will this help those populations? We talked about equity earlier, but how will this make a difference for all Washingtonians? And is it kids, is it adults, is it folks, a transgender, BIPOC? I would love to hear from Greg. It looks like you have an answer. And Colette, why don't we start with Greg and then we'll go to Colette on this one.
So this is a huge issue, an enormous issue, just about equity generally, but as we talk about gender identification and how do you begin to, and the key to all this rests somewhat in how we all work together, and then how do we provide services, and the whole provision of services through telehealth, and the ability for us to have the ability for people providing telehealth services here who can reach out to, and we now are collaborating with a group that has transgender SUD providers running groups for teens who are, if not transgender, at least questioning, and we're able to shift people over to them and then back to us. Had this whole adventure into integrated care not occurred, we wouldn't have those conversations. And so furthering that with the support of managed care organizations and accountable care organizations and the state through Medicaid and through other coverages has been enormous to provide care in communities that are, I mean, underserved doesn't even begin to touch it. They're just not served, and they don't get to, it's visually and emotionally being able to connect with the providers that are serving. And so it's been very important.
Thank you. And I want to ask Colette to chime in about the youth and adult. And also we have a question, because this is also about populations and helping everyone, is how this work can make a difference in rural communities where resources are limited. So Colette, if you could comment on the adults, kids, and then rural communities, and I'll give others a chance to chime in as well, please.
Yeah, thank you. Yes, the tools that were developed, the companion sets, they were actually developed by primary care providers for primary care and physical health, and by behavioral health providers for behavioral health settings. So they were developed by a broad group of folks that work in those fields, and it was designed for the adult population, but the designer of the tool of the assessment in New York feels that it's very applicable to pediatrics as well, pediatric children as well. And we did have a pediatric a pilot or practice that participated in the pilot, and felt that it actually was a reasonable tool to use for their practice, and more so than the tool they had been using, the one we had been using for the state. What we are going to do is that this assessment tool is in the public domain. It was developed out of New York State, but it is in the public domain. So there is the potential, and we plan to do some minor tweaking to answer some of these questions that may be more specific for certain kind of screenings, certain kinds of for the pediatric population, particularly maybe more for the SUD population, some of these other populations that we've just talked about. And somebody else, I'd like to speak to the rural areas too. Yeah, if we would.
Thanks. So does anybody like to just chime in on how this can make a difference in rural communities as well as urban, or just across the state? Vicki.
Yeah, I mean, we've seen a lot of engagement in rural communities, particularly with the ACHs and work that's been done there to help support. So I would say some of our rural community providers are probably the most advanced in integration, also because in rural communities, there's less resources typically. I think the providers have felt the burden of needing to be more holistic in their care, knowing there may not be options that are close to those being served such that they can get the care that's needed. So we've, at least for Molina, we've used the same evaluation tool in rural as well as, metropolitan and suburban areas, and had good impact from that. In terms of resources, I think we've addressed, there's resource issues across the state. And I think there are definitely rural issues as it relates to recruiting workforce, whether that's physicians or mental health professionals or substance use disorder professionals. And I don't think there's any answer for that. I mean, there are Suzanne Swedner has been very involved with, or Suzanne Swedner has been very involved from the Department of Health at looking at both the workforce and what's happening as it relates to licensure and participating in work groups around the state to try to look at what we're going to do. But this is very complex, and I don't think there's any quick solution. I do think with the advent of telehealth, both health that addresses physical health as well as behavioral health, as well as, again, both, I think that has really allowed us to outreach to rural areas. But we also know that in rural areas, sometimes there's limited connectivity or a limited access to electronics in terms of technology that will allow those folks to engage that are most isolated. So those continue to be challenges for us in terms of addressing how we can best serve.
Thanks, Vicki. So Colette, did you have something you wanted to add?
Just quick, I think that the assessment will help us, as Greg was saying, to identify those areas where resources can be best applied, policy decisions or funding resources that will help us understand what rural communities and other practices face, and how to funnel our forces and our resources to those groups.
So just in our last couple of minutes, I want to ask a final question about what's next for this work and what are you looking forward to as we move forward? And I'll start with Susan, then I'll go Colette, Greg, and Vicki, and then we'll wrap it up. Susan, what's next and what are you looking forward to?
Yeah, so the next step is to start with a cohort in July of 2022. And the cohort 1 will really be the transition from the MEHAF tool to the new tool for those providers across the state that have been completing the MEHAF under the current waiver will switch to the tool, and we'll be developing trainings at the end of this year and early next year to support providers in doing that. There also will be some providers that have experience completing some of the MCO tools will roll into that cohort 1 as well. And we're going to get it started. And this will be, a learning process for all of us to kind of try to figure out how to do this best. But and then the plan is to roll additional cohorts in every 6 months until we can kind of build across the state. The other thing, and you'll probably hear more about this in the next session, but the state healthcare authority is applying for a renewal waiver, and we're hoping that integration efforts will be a part of that. So it will continue to bring resources that can support some of the particularly the training, technical assistance, and practice coaching to offer up to providers going forward. But we're really excited. We think this is the right way to go and is going to give a great statewide perspective of what's happening, the progress being made, and allow us to tailor resources to the needs of the various providers.
All right, so lightning round, because we're just about done. Colette, what are you looking forward to? What are you excited about?
Great, same as what Susan just said, but also just knowing that we will, and I just lost my train of thought. Just lost my train of thought. I'll come back to me.
That's all good. That's okay. Greg, what are you looking forward to?
Everything Susan said.
Vicki, what are you looking forward to?
Of course, what Susan said. And I'm looking forward to us continuing to learn. I think this is just tremendous effort that everybody's making. And I think we have lots of opportunity to continue to build on our successes and to continue to improve. And I think this is going to be a vehicle for us doing that. And I think that at the end of the day, we all do this work because we want to serve people in the community and do the very best we can. That's why we all showed up. That's why we're in our professions. And I think to really
see this culminate in better services, super exciting.
Great, thank you so much. We've put in the chat where you can learn more about the tool, and I see we had a question about you. Where is it? Please check out this link. There's also an email you can send. You can send questions to. This is a great opportunity to improve health across the state. It can feel technical, but it's really important that we make a difference for everybody, and whole person care can help do that. Thanks so much, everybody. Thanks so much to the panelists and for all the work that you've been doing to move this work forward. It's so important. Thank you, thank you. We have 15 minutes. We have a 15-minute break. Please be sure to come back for the next panel. That will be at 9:45, and it will be focused on the Medicaid renewal and the future of ACHs. Don't miss it. Please come back. Thanks again to all of you.
Thank you.